So welcome everyone. Thank you so much for coming. My name is Laura McLaughlin, and I'm working to set up this Community Hospital Homeless Health Education and Learning Series. Today's session is on shelter intake drop-in or 24-hour respites, and we're very lucky to have four excellent speakers: Sharon Campbell, who's the manager of Central Intake; Milton Barrera, who's the manager of the Women's Residence Portfolio at the City of Toronto; Jamie Facciolo from Homes First, the Director of Housing and Shelters; and Sherry Hayes, who's the Senior Manager of the Women's 24-Hour Drop-In at the Fred Victor Center. Great. Yay! Speakers! So basically the way this session is set up is as follows. We're going to have a short introduction to homelessness in the City of Toronto. Then Sharon's going to present around central intake. Milton will present around the medical intake. Jamie about the programs at Homes First. And Sherry about the programs at the Fred Victor Center. There's half an hour at the end for questions and answers, but if you have questions during the presentation, you can always raise your hand. Great, so the objective of today's session is to build understanding of the shelter drop-in and 24-hour respite system and knowledge on how to access and navigate the shelter drop-in and 24-hour respite services effectively for your patients and clients. Great, so Jamie and Sherry, if you want to take over.
Sure. Hello everybody, thank you for coming and spending your lunch with us. So Sherry and I will be kind of going back and forth with some slides here, and we thought we'll start off with a brief overview of homelessness in Toronto right now. So as we all know, homelessness is a complex, urgent, and growing issue in Toronto, and there are currently approximately 8,700 people in Toronto who are homeless, and many more of those are experiencing hidden homelessness. Thousands of others are on the wait list for supportive housing. So the chronically homeless, those are those homeless for 6 months or more within the past year. They are the hardest to help, as they are often also dealing with other issues such as addiction and mental health. And a person of no fixed address faces major barriers to finding a primary physician, social support, or keeping in touch with family. Part of the reason is Toronto has a shortage of affordable and, most importantly, supportive housing. Many homeless people are relying on temporary shelters, emergency services, or a friend's hospitality. Others live rough in the city's parks, ravines, and alleys.
So I'm just going to go over a few brief definitions so that we have a common understanding of what it is we're referring to. So in terms of emergency shelters, an emergency shelter is a homeless shelter program that can be accessed by any individual or family experiencing homelessness with or without a referral. So that means somebody can just show up at a shelter and hopefully get admittance if there's a bed. Otherwise, a call is made to secure shelter elsewhere, or they can be referred by another shelter, by central intake, by hospitals, by pretty much anyone, anywhere. A transitional shelter is a homeless shelter program that provides required specialized programming and can be accessed by eligible individuals and families experiencing homelessness by referral only. So typically there is a criteria that needs to be met in order to be admitted. There's a process. For example, Fred Victor has a transitional shelter for older women, criteria of being 55 older, complex medical health issues, that kind of thing. So a person would go through an interview process to secure a position, secure a bed there. The Toronto Homeless Help website lists all the program locations as well. A drop-in provides daytime locations, which include a range of services, which may include food, showers, laundry facilities, health services, information and referrals, and social and recreational activities. Services are provided in a welcoming, safe, and non-stigmatizing environment, and they operate year-round. A 24-hour respite provides essential services to individuals experiencing homelessness in an environment that prioritizes ease of access to safe indoor space. Services provided include resting spaces, meals, and services referrals. We often talk about low barrier services in this sector, and this definition is as per the 24-hour respite standards. So low barrier services include 24-hour respites and drop-ins, which are allied shelter services, where service users who are vulnerable and who may not access shelters can receive services in a less structured environment. And some of these things are, for example, curfews. So shelters typically have a curfew, whereas certainly in a 24-hour drop-in, there is no curfew. People can come and go as they need to. The provision of essential services to individuals experiencing homelessness includes cots, meals, and service referrals in an environment that prioritizes ease of access to safe indoor space. Low barrier services are less structured compared to shelters. For example, people don't have to register to receive services. So some of the common health issues amongst the population who are using shelters, 24-hour respites, and the drop-in system include wounds, chronic illnesses, diabetes, acute infections, rashes, lice, scabies, mobility and age-related health issues. We do see a high number of elderly folks using these systems. Mental health issues, sometimes diagnosed, often not diagnosed or being treated. Substance use issues, pregnancy, including women who are using substances with no proper health care, and neglected health care, people who are new to the country without status, or people facing extreme poverty, and lots of folks with multiple health issues, both physical and mental.
Okay, so we thought it useful to go over some data as well. Some of you may be aware of this data. Some of you might be surprised by it, but we should all be concerned about it for sure. So on any given day, over 8,700 people in Toronto are now experiencing homelessness. For every 10,000 people in Toronto, 30 are homeless. In 2018, nearly half of Toronto's homeless population reported being homeless for over 6 months, which makes them chronically homeless. Over half of Toronto's population live with a mental health or physical illness. Over 30% of Toronto's homeless live with a mental health issue, and over 25% live with an addiction. 94% of those experiencing homelessness in Toronto want permanent housing but face barriers in securing it, and 80% said they need more affordable housing options. So in the past 10 years, the average market rent for a one-bedroom has increased by 33%. And in that same time, Ontario Work shelter benefits have increased by only 10%. So we can see some of the causes and reasons why we have a number of 8,700 people homeless. Here's some numbers put to that. So the cost of homelessness, estimated annual cost for one person experiencing homelessness is between $87,000 and $161,000. We estimate now that there are approximately 235,000 homeless people across Canada. And again, our population here is estimated about 8,715. So 8% of Canadians over 15 who have experienced hidden homelessness, defined as without homes of their own and relying on friends or family for shelter in their lifetime. And just some costs associated. So the average cost monthly for someone to be in a provincial hospital bed is about $13,950. In a jail cell, $9,420. In a shelter bed at Homes First, which is part of a program that we have called Strong House, which I can speak to a little bit later, it's about $2,129. And a social housing unit within our organization is $1,545. Okay, I think that's us for, on to Sharon now.
Thank you. Alrighty, so we're going to talk about central intake as it relates to City of Toronto Shelter Support and Housing, SSHA. Okay, so the City of Toronto Shelter Support and Housing Administration Division helps low-income and vulnerable residents find and keep permanent housing by investing in and coordinating a range of housing and homelessness services and supports. What we do at SSHA, we provide more than 7,000 emergency and transitional shelter beds in 65 locations and through motel programs, mostly used by families. We oversee the operation of 55 shelters, plus funded by community agencies, and directly operate 10 shelter programs. We also directly provide street outreach through Streets to Homes, which is our Streets S2H program, 129 Peter Street as well. We fund and oversee community agencies that support services such as employment support, winter 24-hour respite, and housing stability services. And we also provide funding and oversight of social housing in Toronto, which includes direct management of access to subsidized housing through the centralized waiting list. Why do we do it? Well, we contribute to healthy communities by ensuring that people have a range of shelter and affordable housing options, by providing temporary shelter and 24-hour respite services for individuals and families experiencing or at risk of homelessness, services that help them find and keep housing and permanent housing options. So in 2018, SSHA outcomes, 25,800 people were provided with safe indoor overnight space. And we also 8,300 people moved from shelter to permanent housing. So those are some pretty good outcomes. So in reference to central intake, about a year ago, we spent some time at central intake just really redefining our work, ensuring that we were clear on our mandate, ensuring that we were able to provide support to community agencies. We took a lot of feedback that we heard from community agencies, hospital staffs, et cetera, as it related to when you were trying to access central intake, which is our over-the-phone call center. So at central intake, our mandate is to provide a 24/7 telephone-based service that offers referrals to emergency shelter and other overnight accommodation, as well as information about other housing stability services. We're going to talk a little bit more about what those other overnight accommodation, we've briefly touched on it in the opening, which is, the 24-hour respites and drop-ins, et cetera, but we're going to go into more details a little later. The purpose at Central Intake is to ensure people experiencing homelessness who request emergency accommodation over the phone have access to timely, accurate information about available services the first time, every time. So I just want to acknowledge those of you who helped to provide feedback to us at Central Intake. This is what we heard from you that we needed to do, and as a result here it is it's demonstrated that we've been doing that this past year at least. The role at Central Intake, as I mentioned, is to refer callers experiencing homelessness to available temporary emergency accommodation. And we do that by completing an assessment of the caller needs. We also provide callers with referral to available city managed administered shelter and 24-hour respite services. We provide callers with connection to other appropriate temporary accommodation. We also provide information about housing stability services, and we offer callers information and connections to services that provide homelessness prevention and diversion. And last but not least, we provide callers with connection to homeless prevention and shelter diversion services. Over-the-phone services provided by SSHA through Central Intake, as I mentioned, shelter referrals. So this is the communities that we work with, singles, families, 24-hour drop-ins, 24-hour respites, telephone intake, it's over the phone. So a lot of times when we do refer to a shelter or respite program or drop-in, et cetera, sometimes the information when you're working with the person in front of you, it may look a little different. We're not verifying anything because it's over the phone. And as much as we try to get callers to give us the information, if they tell us their name is John Doe, for example, we're still going to provide them with a referral. So we want to make sure that, I know that that's been some of the feedback we've received at Central Intake, that some of our referrals are not always as accurate, but just keep in mind that it's over the phone and we're not able to verify in person. We provide comprehensive homelessness prevention and shelter diversion. We liaise and advocate with housing providers, Ontario Works, ODSP, healthcare providers, etc. And we also provide specialized services for women and children fleeing abuse and newcomers to Canada. So as it relates to hospital discharges, when calling Central Intake, when a caller is being discharged from a hospital, they must be able to perform the following in terms of us being able to make those referrals. That is activities of daily living, can transfer to bed, can live independently in the shelter. My colleagues here will spend some more time digging a little bit deeper into what that looks like. Also, some guidelines to support discharges from hospitals to shelters. So we know that you want to contact with the site where the person is being referred to. We strongly recommend that, and they will again go into more details as to why. You're able to then have that one-on-one conversation and be able to really thoroughly assess. So we're advocating for that when it comes to, I think, more along the lines of complex discharges. Guidelines, again, formal discharge plan and process to share information with sector agencies. Agencies include our shelters, or drop-ins, and they will talk a little bit more about some of the other ones. Not all shelters offer health services or are able to care for people who are ill, and that's really important. I think there's this sense that all of the shelters have nurse and supports on staff and things like that. That's not the case, so they'll get a little bit deeper into that. And again, not all of our sites are fully accessible. I know that the City of Toronto is really pushing for that to happen, but it's going to take some time for us to make sure that the 55 plus sites that we're working with, plus our, the 10 directly operated shelters are all accessible. And there is a plan, there is a citywide timeline that's allowing those of us who don't have accessible spaces to be able to do so. People share bedrooms in most shelters in Toronto. No privacy or the ability to heal properly. Certainly more of the newer shelters are moving away from dorm-like settings, but I know our respite programs, we're still, because we want to meet the needs of the community, and so some of those spaces are just not appropriate. And then last but not least, there's no health services on weekends or after business hours. So if you have, if the client is requiring a lot more health supports, that's also a challenge. Thank you.
So good afternoon, everyone. I'm Milton. So I'm going to talk about the medical intake that we have at Women's Residence. I am the manager for the Women's Residence portfolio. All right, so not sure if people are familiar with Women's Residence. We are located at the corner of Bathurst and Dundas Street West, 674 Dundas Street. We have 121 beds, 4 floors. 3 of those floors are where the rooms are. Our rooms consist of all our rooms are shared rooms, anywhere from 2 people per room up until 5. We do have 1 dormitory where it has 8 people in a room. We do have nursing supports at Women's Residence. We have a full-time RN and a part-time RPN. But keep in consideration, we do have 121 clients. Not all 121 clients need support with their healthcare needs, but at least 49% do. In addition, we work with the Intercity Access Program, which provides us with PSW supports and a RPN for 4 hours a day. All right. So Women's Residence historically has received many discharges from healthcare institutions, and we created a medical intake that would help us and really help the client have the best service possible when there was being a referral sent to us. And really the purpose of the medical intake was to determine the needs of the individual, their medical history, physical and mental state, and any additional requirements. We want to make sure that the appropriate supports are put in place to meet the needs of the individual being admitted into the shelter environment from a healthcare facility. Really what it comes down to is, can they manage their healthcare needs? We do not have PSW staff on shift. We have what's called a client service worker. So they are trained, but not to the same degree a PSW would be. Our building is accessible. However, the individual does need to go downstairs for meals, does need to go to the washroom because the washrooms are communal. They're not inside the rooms. So there's a lot of mobility that needs to happen amongst the individual. And that's why managing their healthcare needs is vital for a reason that we would admit or not admit someone into our program. So the history, as I indicated, we wanted a smooth discharge from healthcare facility to shelter. any transition plans, especially if there's any follow-up work. We want to make sure that there's capacity and skill to support the required follow-up and the current needs. We also want to make sure that we understand and there's a plan around potential impact to operations. We have 121 women. All it takes is about 10 women who are high needs, and that will, tilt our staff needs in one direction where we don't have the ability to provide service the way we'd like to the rest of the women that are living with us. We definitely want to prevent the ping pong effect, which maybe many of you have experienced, where the individual is coming to shelter and then being sent back to the ER and then back to shelter or drop-in. That's a real disservice for the individual, so we wanted to eliminate that. We also want to consider the ability of a client to manage their own healthcare needs versus sole focus on disabilities. So historically, people focus on the disability. We moved away from focusing on the disability and more about managing their healthcare. On paper, someone can look very complex, but in person, they can actually manage their healthcare needs. We're all good, right? So that was a major point that we changed our direction on. So when it comes to shelters or respites, there are the Toronto Shelter Standards and the 24-hour respite standards. And basically, these are standards that have been set for anyone who's funded by the City of Toronto that they have to adhere to. And it's the minimum expectations that clients or staff or the operator should be providing while receiving funds from the City of Toronto. So I'm going to refer to some of these standards that relate to healthcare. So under shelter standards, section 10.2, health and mental health services. Shelter providers will support clients who seek to address their health and mental health care needs. At minimum, shelter providers will assist clients with finding appropriate support services and make referrals when a shelter cannot provide the requested health and mental health services. So the way this plays out is sometimes we may get called at women's residence saying, hey, we have an individual with some healthcare issues. We may not be able to provide that service, but I'll reach out to Jamie or any other women's shelter and negotiate and find placement there. So that's kind of what happens, and that's how we adhere to this standard. For both shelter and 24-hour respites, section 8.2, referrals. When referring a client with health issues to another shelter, shelter staff will first communicate the health needs of a client to the receiving shelter with consent from the client to ensure that the receiving shelter is able to accommodate the client prior to executing the referral. Really, this applies to shelters. It's a shelter-to-shelter referral that we need to adhere to. 6.2, regarding 24-hour respites for referrals. When referring a client with health issues to another program staff will first obtain client consent to communicate any health needs to the receiving 24-hour respite site, shelter or program, and then will ensure that the receiving location is able to accommodate the client prior to executing the referral. Just an asterisk, note that the clients can be transferred within the shelter and 24-hour respite settings once discharged from hospital. So that's important because sometimes if there's follow-up or the discharge planner or whoever needs to contact the shelter, it's a way where we can communicate back to the hospital or healthcare facility saying this person has been now referred to a different site. Section 11.1, health standards. If a client appears ill or has an illness that presents a health risk to other clients, shelter providers will encourage the client to seek medical treatment and, where possible, to facilitate referrals to community medical resources in a manner that complies with the requirements of Section 8.2 referrals. So sometimes what we'll receive is our calls to say, hey, how come this person came to the ER? If it's just a foot pain, why not a walk-in? We try our best to ask our clients to go to the walk-in or to their local GP. And in some cases, some sites may actually have walk-in clinics coming to them. We encourage that. We do not want clients going to the ER if it's not an emergency. However, choice. Many of our women or clients in general may choose to go to the ER. So we fully understand and we are working But again, there's that choice base, and that's why sometimes you get clients going to ER instead of the walk-in. Section 9.1, health standards. If a client or staff appear ill or has an illness that presents a health risk to other client staff, providers will encourage the client staff to seek medical treatment. Really, that is applied to our staff. We want to make sure that everybody's safe and healthy in the workplace. So when it comes to a medical intake, the default is not that a healthcare institution calls us and automatically we do a medical intake. We do have some prompt questions that will determine if a medical intake is needed. And basically, we do a pre-assessment. And that pre-assessment consists of, is the person being referred from a healthcare facility? Yes or no? How long has the client been in the healthcare facility? If it's overnight or even for an hour, because someone went in for just, a sore tooth, that's not going to require a medical intake. That'll just go through our regular process. However, if the person's been admitted into the hospital and has been there for 4 months and now ready for discharge, well, that may require a further dialogue, right? Can individual manage their ADLs? That's important. So one of the things that we try to emphasize to healthcare professionals is that someone may have a good baseline while they're in the hospital, but when they go to the shelter, there's a lot of effort that needs to be placed. So someone may be recovering, but our beds are really low. Unfortunately, I didn't bring any photos, but we have metal beds. They're not the same height as hospital beds. As I indicated before, many of our individuals have to move from bed to the washroom, from bed to the dining room, from bed to the laundry. There's a lot of effort, and a lot of strain and pull. And what we have noticed is that someone whose baseline is okay, after a few days or after a few weeks, all of a sudden their baseline starts deteriorating because they haven't had enough time to recuperate. And we're back to the hospital. So that's something I want to make sure that people understand when we're talking about the ADLs as well. Can the individual transfer on their own? So by default, if someone requires a 2-person assist, more than likely we won't be able to admit. But if the person requires a 1-person assist, obviously that's something we would work with our partners, with the PSW agencies to support us. The existence of mental health issues. Client referred, sourced, or asked if there's a mental health history. So similar to physical disabilities, mental health, especially when it's undiagnosed, can have impact. And we just want to know, hey, how long has the person had some symptoms of mental health? Or even if they're in the hospital, have they met with psychiatry? Because sometimes we'll request that if there are symptoms, can they see psychiatry and hopefully get the ball rolling. Things to take into consideration is the level of care needed. Is it something that we can support at the shelter? The reality is that women's residence is one of the shelters that can support many of our high needs, and if women's residence can't, more than likely the rest of the sites that are women-only shelters may not be able to do as well. What are the support and services needed? Need for appropriate and effective negotiation with shelters. So kind of what I said earlier, we may not have vacant beds or we may not have the capacity to provide service because we may have 10 other complex health issues with other clients, but I may call other shelters, women only, to negotiate and say, hey, can you take so-and-so, or can we swap? And that has worked, and it works well. We also want to set a date and time of admission to align with operations. So often I get there's pressures to discharge patients, especially if they're no longer acute, but if there's a discharge happening at Friday at 3 p.m., we will want to do it on a Monday to Thursday. The reason being is that, especially if there's PSW support that needs to be put in place or any OT equipment, we want to make sure that PSW staff or the equipment is in place upon arrival. Many times we'll get in the system, it'll be that PSW support has already been put in place. It's a Friday, and then they can't find any coverage for Saturday or Sunday, so that person's not being seen by a PSW until Monday. So again, it's always going back to not disservicing the individual. And then we also want to determine the best location for the person within our facility. The medical intake can take place over the phone or in person or in case conference. It's also important to note that you don't have to be a doctor to do a medical intake. It can be anyone who can do a medical intake. Often one of the questions we'll get is, does a doctor have to fill out this medical intake form? No, it can be anyone who is doing the referral. And that is it.
So just going to take the opportunity to share a little bit about Homes First Society. As I mentioned, I'm the Director of Housing and Shelters there. I've been with Homes First since 2001 and started off as a relief staff there and worked as a frontline worker, as a supervisor, as a manager, and now as a director. So I've been involved in every department in the organization. And I'll tell you a little bit about Homes First. So Homes First has been providing supportive housing and shelters for over 35 years to all populations with a specific focus on the chronically homeless, people with complex mental health and addiction issues, and seniors. Our mission statement is to provide affordable, stable housing and support services to break the cycle of homelessness for people with the fewest housing options. So what that means is in our shelters and in our supportive housing, we are mostly serving individuals that are dealing with a multitude of issues. So not just mental health or addictions or physical disabilities, but usually all of them combined. So currently we're operating 19 buildings, which include 5 shelters, serving over 400 men and women. And we have 14 buildings with varying levels of support, providing homes for more than 450 men, women, and children. We have also ventured into providing respite services in the last couple of years, and most recently we operated a respite service on George Street across from Seton House, as well as a large respite in the CNE grounds last year. So we inherently operate under what is termed the Housing First model, and we believe that housing is the keystone to stabilization. And our housing varies from, again, shelters, respites, to shared accommodation, to self-contained units, and we have 14 townhouses that serve families. With respect to accessing our services, our services are accessed either through central intake, walk-ins, self-referrals, and our supportive housing, which is a little bit different than the Housing Connections centralized wait list, as we are an alternative housing provider. So we manage our own wait list, and we use a placement strategy, trying to ensure the best success for the individuals that we're bringing in. So depending on their needs and the environment, we try and place people in a location that's going to provide them with the necessary supports to ensure long-term stability. So just a few programs, additional programs that we have going currently. So we have what we call the Rooming House Project, which is a partnership with another organization called Dixon Hall and EcuHome. And this project is supporting clients and residents who are living in the rooming houses in Cabbagetown, who have not had any supports ever, and so we've come together as 3 organizations to develop a support team that goes in and provides a variety of services around housing stabilization, eviction prevention, harm reduction, as well as trying to build up community engagement in that area and get people involved in that. One of the other programs that we recently were involved in, again, is a partnership, and we believe partnerships are really important in achieving what we need to in the city. So St. Elizabeth and Inner City Health Association is called Journey Home Hospice, and that is at our main location at 90 Shooter, which is Jarvis and Shooter. And we started off with 4 transitional rooms in that building that are providing palliative care and supports for individuals that we would see otherwise in the shelters or experiencing precarious housing. And so that can be done through direct referral as well to access that program. And it's been very, very valuable to the sector. We believe in that. We're in the process of extending that to a full permanent 10-unit program. And it would be my hope that we look into other areas of the city to add programs like this in our existing sites. Follow-up supports program. So that's, we have a small team within our organization that provides supports through referrals coming from the City of Toronto. We get referrals for individuals that are just being housed, usually in private market housing, but require some level of support to try and maintain that. So we have a team of what we call intensive case management workers who their role is to engage with them and keep them housed, really. Keep them housed and improve their overall quality of life. Case management, intensive case management workers, again, we have that set up in our shelter systems as part of the new shelter service model. We have developed teams in the shelters now that have their own supervisor. They have liaisons to work with the hospitals and other healthcare providers to provide supports while the individuals in the shelters, but also with a real focus on searching for appropriate housing. Hoarding intervention. So one of the largest barriers that we see for individuals that are experiencing complex needs are hoarding issues. We see a lot of people evicted or facing eviction because of hoarding issues. So we implemented a program within our portfolio that has a team that is dedicated to working with individuals on a one-to-one basis to try and address some of those issues and reduce their hoarding to a level where they're living in a safe environment and a healthier environment, both physically and mentally. Life skills, again, is something that we have built into our shelter system. We have life skills workers that work and provide programs around recovery and other types of programs like housing readiness, just groups that get together and talk about issues, things like that. Harm reduction, I think I mentioned harm reduction in the rooming house project. So within our other portfolio, we have developed a harm reduction program that has staff that implement harm reduction strategies, that run workshops and webinars, that ensure that we have supplies available for all of our residents in our shelters and in our housing portfolio to allow our residents and shelter users to access. And again, 24-hour respites, I mentioned that earlier. Winter is upon us, so I'm sure we'll be ramping up for respites shortly. Features of a successful transition from hospital to shelter. So Milton talked a little bit about this earlier, and really kind of what we want to illustrate here, and I think I'll use maybe a general kind of case study that will illustrate how things can go wrong and how things can go right. So some of the main features of a successful transition from hospital to shelter. The most important one is communication between hospital discharge planners and shelter staff. Without that communication piece, there's a lot of assumptions made on both sides, and in the end, what happens is that the individual is the one that suffers, right? So that's really important. And collaboration between various stakeholders. So there might be not just the shelter staff and the hospital staff. There may be other supports in place. There may be other shelters that want to come in, that need to be brought to the table to have that discussion so that we have a successful transition, not just the transition, but also the stay and the ability to support that client in a dignified and meaningful way. And so some of the things that are important to do or that can be done is case conferencing, and as Milton spoke about earlier, requiring services to be set up prior to discharge and coordination of time for discharge. So just as an example, I'll say, let's take Joan, 60 years old, in a wheelchair, has behavioral issues and also has an ostomy bag. So she's been discharged from the hospital to the shelter. She gets to the shelter and we don't have any knowledge of any services set up. So the next day, Joan is struggling to change her ostomy bag and she's tracking feces throughout the entire shelter. So we have 90 people in the shelter who are yelling and screaming about this, right? Obviously, this is not good for Joan as well. So we have to send her back to the hospital because we obviously don't have the capability to manage that. Again, in this particular shelter, we don't have health services, or if we do, we have health, maybe a nurse or a doctor that comes in once a week. So we can't manage this issue. We have to send back to the hospital. So what do we do differently this time to make it work, right? Well, we have a social worker or a discharge planner who now is communicating with our shelter staff or our shelter supervisor. We set up a meeting, a case conference at the hospital. We invite other support services. For example, Joan has a caseworker from another external agency because she has behavior issues, maybe some mental health issues. We all sit down and we talk about the issues, what is going to need to happen for a successful transition, and what's going to need to happen for us to be able to continue to support Joan in the shelter rather than having her experience the ping pong effect that Milton spoke about, right? So we lay out a plan together and we work coordinatedly to implement this plan. And what that looks like is we ensure that the caseworker knows where she's going. And we set up a schedule for the caseworker to be there a certain number of times a week. We ensure that services are set up for nursing and PSW, and we have confirmation of what date they're going to start prior to discharging, right? Then we meet with our team at the shelter and we give them a brief on what they can expect. And then we coordinate an exact time as to when that discharge is going to happen. So we're not going to be doing that on a Friday at 6 p.m. We're likely going to be doing that on a Monday or a Tuesday where the staff team is prepared and all these things are in place. So Joan comes back to the shelter. That day she gets there. That afternoon she has supports from a PSW. She has supports from the nurse. The team is aware of what the issues are and how to deal with it. And Joan is way more likely to be successful in that stay. We're not having to send her back and forth to the hospital, and we have a successful transition. So this is a case. I mean, there's a number of cases that are less complicated than this, but these are the cases that really require these steps in order for it to be successful. And obviously, our first goal is for it to be successful for the client, but following these steps saves a lot of time, stress, and headaches for the hospital, for the shelter, and most importantly, for the client. And that's it for me.
We're almost there. Fred Victor Center, originally Fred Victor Mission, is a not-for-profit, multi-service, community-based organization committed to ending homelessness. And we've been in existence for the past over 125 years in the city of Toronto. A long time. Currently, we operate about 20 locations across the city. We support over 2,000 people each and every day and serve over 70,000 meals every year. Last year, we housed 497 people, provided mental health case management to 1,215 people, and provided employment service for over 1,000 people. And our mission is to improve the health, income, and housing stability of people experiencing poverty and homelessness. And our vision is healthy and thriving communities where every person has a home and access to opportunity. Some of our housing and health services include affordable housing, family housing, transitional housing, transitional shelters, emergency shelters, and a 24-hour respite center. In terms of health, we have health information and community services, community mental health and outreach services, specialized support programs, and supervised consumption services. In terms of our shelters, drop-ins, and 24-hour respite services, there's access to one-on-one support, crisis management, and counseling. We provide our services from a housing first framework and use enhanced case management and housing access support, including follow-up. We offer programming, meals, ID clinics, access to income supports, harm reduction services, which includes supplies, counseling, harm reduction groups, access to street health nursing clinics, as well as we do at the drop-in have a shared care team from CAMH. We offer assessment of mental and physical health, financial, housing goals, recreational and vocational needs. And we also have concurrent disorder services, as well as geriatric case manager services for our transitional shelter for older women. That's it. I think Lara's maybe going to finish up. No? Milton is.
There's one tool that we want to make sure you're aware of. And if you don't know, then surprise. So it's called Toronto Homeless Help. City of Toronto has created a tool for anyone who may not be familiar with our emergency shelter system or the shelter system as a whole. And basically, it's user-friendly. You click on, if you're looking for a 24-hour respite, you click on it, and it will give you a map of Toronto and where the 24-hour respites are located. And if you click on the tag, it will show you the name of the operator, the address, and the client group. Mixed adults, women only, men only. And again, it's really helpful for a lot of people who may not be familiar with our system. Same thing with shelters. It will populate and show you all the shelters in Toronto, right? So not sure if people were familiar with this tool, but if not, Homeless Help, definitely something that will maybe save you time.
Awesome. Thank you so much. So we have some time now for discussion. Any questions that you may have for any of our speakers? I'm also passing around a sheet, so if you could just make sure that your name and email are on that, just put a check, and if it's not, just add it, and I will send you a copy of today's deck.
So, Laura,
Yep.
so you maybe put back the contact page, because if people don't have questions now or they think of questions later, we provided our information, our individual information, so feel free if anybody wants
Yeah.
to contact us at another time. And I think there is a question.
Yeah, so with the user-friendly website that was just shown to us, which shows where the shelters are in the city, does it tell us which shelters are accessible and which shelters have space?
Just to repeat the question, just so that it's on the video, the question was with regard to the user-friendly website that was just showed, and we'll open it up again in a second, does it indicate which sites are accessible
And if they have space.
and if they have space available?
So although we want to refer you to call central intake, we understand that central intake is just one point of contact for folks in terms of choice that we briefly mentioned earlier. So what I would recommend is that definitely encourage your client to call us at central intake, but certainly the phone numbers are on there. In terms of space, they may or may not be able to give you that information, and some of them may also redirect you to call central intake.
So this is just a map.
Yes. And you're able to, when you contact those shelters, you're able to have more specific conversations, especially if you're talking about discharges from hospitals. Are you from the hospital or from a shelter?
Health Center.
Oh, okay. So yes.
So, yes, it's a map, but it's also a filter. So if you actually, unfortunately, I'm not sure why the actual map's not
Click on the
working.
list. Click on the list view.
But you can also filter over here. So, are you looking for man, woman, youth? It just saves some time versus maybe looking at 211 or a list of various drop-in shelters and respites that you may have. Specifically, if the individual has said, hey, I want to look for something in the north part of Toronto, you can filter it. It just, again, it's a guide, right? We aren't there, there's been some asks. It would be great if we could get some photos so that way you could see the images of the rooms. And so, this is the initial. I do hope there'll be enhancements, but we had to start from somewhere.
And to add to that, though, I would say I would take that back. Like, I'm interested in the question about the accessibility part. So I think that's really good, and I would definitely want to take it back to the lead that's responsible for this, and that might be one of the other filters that they can add.
But I think it's great where we can visually see where shelters are. The big problem is there isn't space. So there could be a shelter, but you can't go there. So that's helpful. If it could be live online where we would know, all right, I'm gonna click on this, like central intake, but a way to just kind of fast track for these.
Just to repeat that. Okay.
Especially with accessibility and all the broken elevators.
So the comment is with regard to the tool and how helpful it would be to not only see where the sites are located geographically, but which ones have space available. And the recommendation is to create a live interface or tool where workers could access information that was real time around space.
That's good feedback.
And the response from central intake is that's excellent feedback that will be taken back.
So I was just checking on my laptop. So when you actually click on any of these sites, there's a detail link. And when you click the detail, it actually will give you more information, right? So if a facility is pet friendly, it will also indicate if it is pet friendly. So let me just, that's easier if I look over here.
Why isn't the map coming?
I'm not sure why the map is not.
Oh, it's an add-on.
So again, it's not going to give you exactly what you're looking for, but if you do click on the details over here, you can see it's 4:30 p.m. to 8:30 a.m. of services, and it's met. And again, depending on the site, there might be different variation of details.
And just one other that would be really helpful with that, that group of, just user friendliness, a link to streets to homes.
The comment is that it would also be helpful to include a link to Streets to Homes on this website.
So tell me a little bit more what you mean a link to Streets to Homes.
How people can access that program in a more user-friendly way to add in, like, just because they are such a resource-rich program that can help with so many situations and access.
So for example, 129 Peter Street specifically, I believe that's on here as well, but if it isn't, that's really good feedback. Yes.
It seems like a little bit of a labyrinth.
Yeah. I believe it's on there. We have some staff from Central Intake. Yeah, I'm pretty sure that 129 is on there as well. Yes.
Okay, yes?
I just have a comment that just from patients. A lot of them feel unsafe going to shelters. Safety, like a big concern with shelters at the moment, or is there anything that even I can reassure patients that their safety is going to shelters or okay, rather than having them on the streets and when the shelters.
So the question is around safety and the need to reassure patients that a shelter is safe or has safety protocols or policies in place. So what information is there available about safety that could be accessed by workers?
So Jamie, Sherry. So actually, before we get to your answer, the first thing we would like anyone to ask is whether or not the individual wants to go to a shelter. Often what we encounter is that the person, because they have a no fixed address, the assumption is they're going to go to shelter. And then we start the whole referral, and then the first question that most of us will ask at the shelter is, do you want to come to the shelter? And they're like, no. So that's the first thing I would say is, do you want to go to shelter? But I'll let Jamie and Sherry answer the question you had.
Yeah, I guess there's some fear about shelters, but we talked a little bit earlier about shelter standards, and so there are guidelines for all of our shelters with respect to safety, health and safety issues, with respect to staffing. So again, we do everything we possibly can to ensure a safe environment, having enough staff on site, putting protocols and policies and procedures in place. We don't see a lot of violence in the shelters at Homes First. We very rarely see that. We see more disagreements and arguments than we do violence. So I can understand why people might feel that way in a large, dorm style shelter. It's obviously not optimal. It's not what we want. We want housing and supportive housing, but given the issues that we're currently grappling with homelessness, around 8,700 people, we're doing the best that we can with what we have, right? And so we put all the things in place to try and do that. I don't know if that's a real answer. I mean, how do you really relay that to somebody who has a fear of going to a shelter? They may have had something happen to them previously in a shelter, and that may have put them off to all shelters. Again, all I can speak for is the shelters that we operate, and from what my colleagues tell me and the data that I see, we don't see a lot of violent issues in the shelter system. So I don't know if you want to add to that, Sharon.
Yeah, I can add a little bit. Certainly all of our staff receive mandatory training in first aid, CPR, as well as crisis prevention, intervention, diffusing hostile behavior, all of those kinds of trainings. I work, as mentioned, in the 24-hour women's drop-in, which is a very low barrier kind of program, and similar to some of the respites, where you have, many people in a space. There's no privacy, a lot of conflict happens, and yes, violence does happen. It's not something that's tolerated in the sense that people will be asked to leave. Sometimes service restrictions are imposed. If it becomes necessary, we like to avoid that, of course, but we're dealing with really vulnerable, marginalized folks with really complex issues, with levels of stress that I don't think any of us can even possibly imagine. So when you have all of those pieces together, it does happen sometimes. But certainly our staff are trained to respond in those situations. We develop relationships with emergency services, Toronto Police Services, to respond when needed, and do everything we can to prevent that situation.
Thanks. The question over here.
I just had a question in regards to addressing the needs of individuals wanting housing or wanting emergency shelters for people with limited ADL who are actually coming from the hospitals, and as a result, if shelters are full or alternative places like the infirmaries are full, what options do they have and where would you send them to?
Okay, the question is with regard to individuals who have limited ADLs, what options are they? Where could you send these folks? In particular, if the shelters are full or the infirmaries are full, where can you go for people who have limited ADLs? Anyone?
That's a really good question that we would like the answer to as well.
I would like to add that, sorry for interrupting, that often these people aren't eligible for inpatient rehab. They don't fit criteria, the bar, that you have to reach to go, that would help them through that.
Yeah, it's a huge issue for all of us, and I don't have any answers. I don't know if some of these folks do have some ideas.
And I'll just repeat that comment around the fact that some individuals may not meet the bar for access to the infirmaries.
I'm sorry, inpatient rehab
hospitals. Sorry, inpatient rehab hospitals. Excuse me. Excellent. Right. So the level of functioning may be too high for the person to be eligible or appropriate for inpatient hospital rehab.
So Jamie and I are going to kind of do a duo to answer your question. So in regards to ADLs, it does happen where you may get another site who has taken someone with a fine, their baseline is fine, but through the course of their stay, all of a sudden starts developing some health issues and they can no longer adequately provide service at that level. They'll call potentially women's residents. We'll do a medical intake with that shelter, because under the shelter standards, we still have to do a referral, and if health information has to be disclosed. We'll determine, hey, yeah, we'll take her and send her to women's residence. And then at that point, if we think that her baseline is above our capacity, we will reach out to our partners to say, hey, we need some top-up hours for nursing or PSWs. So we'll make every effort possible before we have to send this person back to the hospital. We don't want to do that, but sometimes resources are always a challenge. We don't get the PSW supports we need. After we've been requested, we will have a case conference. We'll escalate it to say, hey, we need some top-ups. Because if we don't get some top-up supports, potentially this person might need to go back to the hospital, right? And we'll try to work it amongst ourselves before the individual has to go to the hospital. But worst case scenario, sometimes we have no choice. We'll call Toronto Western because we're right beside Toronto Western. Woohoo! No, okay. You guys, that was a joke. We'll call Toronto Western and say, hey, here's a situation. Is there anything we can work out with, right? Or any of the hospitals that we have developed a rapport with. The problem is staff in hospitals, they change, you know? Like you develop a rapport and then that person gets changed to a different unit and then you kind of start that rapport again, right?
Yeah, I'm not sure. You pretty much covered it all. I was just going to speak to kind of escalating certain situations and bringing as many people into the mix as possible to try and come up with solutions. So looking for certain providers that have that are willing to or have a little bit more support systems in their shelters, or looking for a housing provider that may be able to, that maybe has a placement strategy and has a location that they can prioritize a specific individual and try and get them into that supportive housing environment. So it's really just about escalating and bringing as many people to the table and getting as many options on the table to see what we can do with it. That's the best we can do with that. There are a lot of gaps in the system, and I think there's another session coming up on long-term care and how that relates to the increasing aging population with nowhere to go. So for those of you that are interested in that, I think that would be a really good session as well.
Of the immediate nature of them being outside or having, being in a situation, what is the most appropriate kind of referral for those situations?
So the question is from a central intake staff about receiving referrals after hours for clients that are in an immediate situation of housing need with limited ADLs. So for example, they're being evicted in the moment and they have limited ADLs. What are some of the options or appropriate referrals that can be made for people in that situation?
I don't know. Milton?
Yeah, take it away.
Help me with that one. That's a challenging question. I think. I mean, it really speaks to. I know this is not going to give you the answer right now, but it speaks to what we need to do around supports, follow-up supports, while people are housed, and eviction prevention supports. So if they're tied to somebody, tied to a community, tied to an agency, tied to a worker, it's never the case where somebody is facing eviction at the moment, so there's a process. So if there's somebody there to work through that process, it may not end up getting that far down the line. So that's a larger system issue, and I think it just illustrates why we need to have more supportive housing and more supports in existing housing. In the moment where somebody, I mean, I don't really know that there's a place that exists specifically carved out for that. I think really it's just about trying to find the safest place in that moment for the individual, getting them into that place, and then having the staff in that place work with them to try and get them where they need to be as soon as possible.
Are you also finding that they are presenting with medical issues where you are also saying, you know, maybe this person really needs to go to an emergency room?
At times, yes. So in those situations, sometimes we have to go with what's available, and it's not necessarily what's most appropriate, but what's available, and that is the hope that from there, if they go to women's res or senior house or what have you, that they'll then get the services, they'll get transferred or what have you, but it's definitely a gap area, especially, you know.
But I
And
think,
even from hospitals after hours or, you know, any kind of situation, it's one of those areas where even from our standpoint, because of the limited, space, it's a struggle for sure.
yeah.
Okay.
Yeah, I was just going to say, I think that is the best course of action, is just get someone to a safe place and let the people that are working there evaluate whether that individual can be there safely or whether they need to be transferred to hospital, in which case that would ideally then set up the process that we've discussed, where we would search for a suitable place, have a coordinated response to that, have hospital and shelter working together to find the best solution that exists.
I just want to add, there's a program the City of Toronto operates called EPIC, and it is an eviction prevention program that, in my experience, has supported people who are in crisis situations with eviction, and helping them obtain like an immediate place to stay.
I also wanted to add that if this is someone who's living in Toronto housing and they are in danger of being evicted, Toronto housing will make referrals to a specific set of workers who deal with things like arrears, and that's all based on the fact that someone approximately 5 years ago, an elderly gentleman went to a shelter and unfortunately passed away. And they finally said, but that unfortunately is only, as far as I know, if you are being evicted or if there's danger of being evicted from a Toronto housing apartment unit.
So the comment is that if the person is living in a Toronto community housing unit, there are workers available to help support the individual dealing with arrears, for example, and do everything possible to prevent them from going to a shelter. And that's coming out of an experience where an individual from Toronto community housing who was living there ended up going to a shelter and passing away some years ago.
I just wanted to add as well, if you know someone who is in the process of eviction, they can receive a referral to EPIC through Central Intake.
If you know someone who's in the process of being evicted, they can receive a referral to the City of Toronto's EPIC program through Central Intake before the eviction.
That's the critical piece.
We both kind of had a question. There was reference to PSW Milton is it Women's Rights? Yeah. So that sounds like either together with the hospital or even once someone has arrived, that you can make referrals to the LIN as needed. Or maybe there are some different processes for you.
Yeah, so the question is about access to PSW, for example, in women's res or any type of LIN services. Milton.
Yeah, so the ICAP program is funded by the LIN. I don't even know what the name is now. Is it still LIN? Super LIN? But they are funded, and depending on the type of supports, we sometimes can request additional supports in addition to PSW and nursing supports. And that's kind of why I said earlier that, sometimes we get called from our sister shelters and drop-ins saying, hey, we have a situation, is there anything you can do? And our goal will try to get them into women's residence, but if we find that the needs are too high, then we will escalate, right? So we often, anytime when it comes to female clients, we're often in the table.
Milton, what about male clients and the supports available for male clients?
Repeat the question.
Yeah, I think.
You want to repeat? So the question is, what about the supports for male clients? So this is where, unfortunately, Monica Waldman is not here for the manager of Seton House, but Seton House does have an infirmary. I would say, Monica would definitely be a point person to speak to. The men's sector is a little different. I'm not part of the men's sector. I've been working with the women's sector for a while. I can only speak on behalf of the women's sector, unfortunately.
Okay. There's a hand in the audience around the men's sector. Okay.
The process is pretty much exactly the same for men.
Can you repeat that?
The process for men is pretty much exactly the same as it is at Women's Rest, as it is at Seton House. We don't take men with these complex issues in the hospital because they have to be mobile because we don't have an elevator in the hospital. They'll go to either the annex or the long-term or the infirmary where there's an elevator and there's nursing staff, PSWs, everything is in there.
Okay, so the response is that the process is very similar. It's the same for men. And at Seton House, the way that it's managed is that men with complex health needs are not staying in the shelter, but they're going to the long-term care, the infirmary, not in the hostel, but they're in the upstairs to the fourth floor is where they go, where there are more healthcare supports available. Okay, Amy?
Sorry, that, I don't see how that could be the same as intake to Women's Res, because every time that I've tried to get somebody into Seton House recently, I've been told that they're not accepting people.
So
Especially in the infirmary.
okay, the question is, there's some experience where workers have tried to get access to Seton House Infirmary in particular and have been told that there is no space available there.
And they're just no longer accepting.
No longer accepting clients there.
Part of that could be because of the George Street revitalization, but I want to take your contact information and connect with my colleague Monica Waldman, who's the manager there. Look, I tell everyone whenever there's a concern, I really encourage you to escalate it up to the supervisor and the managers, because things change all the time. And there's a lot of transition that we're all going through it with our city-run shelters. But I definitely, because I get feedback about central intake after the fact, and I'm like, give me a call. So I'll definitely give you Monica's contact, or you can also reach out to me, and I'll try to, bring that concern forward to her.
And I'll put the contact info back here on the screen for our presenters who have kindly made themselves available for any questions or issues that you come across.
I want to add something to that.
Mm-hmm.
I also want to add that there's only so much capacity that we have as well. So that could also be part of the challenge, because we've also tried to refer to Seton House, their infirmary program, and when they're at capacity, they're just one small part of the puzzle when it comes to serving, homeless clients that are in need of health supports. So I think it's a much broader conversation that hopefully at the next presentation about long-term care we'll get some answers. But to me it's such a complex situation because the need far outweighs the capacity.
Yeah, just to add to that, as we were preparing for this session, a lot of the things that started to come up were we determined were the topics for a whole other session, which is system issues, right? So we all know that there's system issues and there's a lot of gaps in the system, and that's what we're trying to do on a daily basis, most of us. And so I think that's you could spend a whole day just talking about system issues, and we definitely know there's a lot of them. So maybe we'll create another session about system issues.
Yeah. And we have time for a few more questions. Go ahead.
And it's probably a misinformed question, but I may I'll ask it anyway. If I were something self-referring to central intake, and I did not speak English, how does that happen?
How does it work if you call central intake?
First language.
and English is not your first language, you don't speak English, what happens?
We provide over the phone interpretation services.
For a whole array of.
A whole array.
Wow.
Yep.
Aside from the in-house and art, is that the only two shelters with medical care and support patients?
Aside from Seton House and the Sherburne Health Center's ARC program, are those the only two shelters that can support clients or men in particular with health needs?
So what I can say from a high-level response, a lot of our shelters that provide services to singles, men, women, etc., are implementing these sort of stopgap services. It may not be everyday health services. It could be a doctor coming in once a week or once a month or every 2 weeks. They're trying their best. I would just encourage you to reach out to, if you're I can't speak for Street Haven, but I know that every one of these shelters are dealing with this issue. And they're doing their best to try to bring in some in-house supports. But definitely at the, with Milton's shop and Fred Victor and here, I know that their supports are there, but we can't speak for all of the other ones.
Okay. I'm going to say something too. Inner City Health Associates provides primary care and psychiatry services in shelters, and their information about which shelters is on their website. We have also put together a directory of health services that are available in shelters, drop-ins, and respites. So if you just connect with me after the session, we can make sure you get a copy of that directory.
Yeah, I was just going to elaborate on what Sharon said. So there is no standardized kind of level of medical care in the shelter system. So within our organization, we do the best that we can to partner up. So that could be through a community care agency. It could be through some of our shelters have a doctor coming 1 day a week through Inner City Health Associates. So we do the best that we can to try and provide as much supports around health in the shelters. But it's kind of a mix match of things. Yeah. Sorry, I
The question is it?
Yes, absolutely. So there's in addition to that.
Okay. Is it necessary to put in a separate LIM referral, or would that be a duplication of services once the client is referred to central intake?
So depending on the needs of the individual and depending on what services we have at that particular shelter, right? So ideally, if you are getting somebody into a place that has a partnership or that has the services required that are going to meet the needs of the client, then you wouldn't need to do that. But in many cases you would, because we only have a doctor once a week and this person might need PSW supports and a nurse 3 times a week, we wouldn't be able to provide that. So you definitely would do a LIN referral for that.
Yeah,
Yeah.
direct to that.
Yeah, I just wanted to add, it really depends where the individual is. If the person is still in the hospital, by default, you have to submit a LIN referral because our coordinator won't touch it until the person physically comes here. And that's another barrier. What we talked about, the seamless transfer, it happens. The LIN coordinator forgets at the hospital put it in, or our coordinator forgets to pick it up, and then that's just time that impacts the client to receive service. The other part to your initial question was about resources. Something to think about too is that we've had situations where all resources are being thrown to us, but we also have limitations. We can't bring in a hospital bed into some of our facilities. As much as we would love to, the reality is just the size wouldn't allow a hospital bed. And that would create potentially an impact to our capacity, which would mean that we would have to reduce a bed in order to allow a hospital bed. And that would create ripple effect. Things like an OT. OT will come in and say, yeah, we'll put in a SASC pool. Then the installer comes and says, no, I can't install it because the ceiling isn't compatible. So these are things that happen in real life where we do want the resources, but due to limitations, whether it's structural or just the way the configuration of the room or the shared amenities, we just aren't able to alleviate the situation.
And I also want to add, in terms of central intake, if you call central intake, the first question is, can the patient perform their ADLs? If the answer is no, then at that point we recommend that you contact Women's Res, Seton House, Jamie's program, etc. But if it is that the response comes back as no, then at that time we're unable to make a referral to a shelter.
Okay, there's just a few minutes left. Are there any other questions? Comments? Okay. Any other? So I'm going to just do a little See Heal plug before I close. So we've got a few more sessions coming up. There's one on Tuesday the 15th. That one is on hospital discharges. And then there's been a new one just announced for October 31st. And that one is on the long-term care application and placement process. And then in November 12th will be the Mental Health Act. So, you're welcome to just send me an email if you're interested in attending any of those sessions, and I can give you some more details. Thank you so much for coming out today to participate in this session, and thank you so much to the speakers. I think this is a really challenging topic, and the way to deal with it is what we're doing. Thank you.